the end, we'll be sharing information as well in a follow-up email. So I'm really delighted to introduce our first speaker, and that's Grace Coles. She's the referrals lead at Doulas Without Borders. She is the general manager with oversight across the organisation, has got a background as a trained doula and teacher, giving insight into working with families from across different backgrounds and perspectives. So really looking forward to this session. So over to you, Grace. Thank you.
Thanks so much, Katie, and thanks to you and Q community for inviting Doulas Without Borders to speak at this webinar. We're really excited to be here and be speaking alongside Madinah and Peter from Bliss as well. So yeah, my role is actually I'm now the organisations director at Doulas Without Borders, and so I've sort of kind of like a general manager role, but I've worked in the referrals department, I've worked in our volunteers department, and I initially came on board as a volunteer doula. So that's just a little bit about myself. And I'm going to start off by telling you about Doulas Without Borders. Some people may know of us, some people may not. We are a voluntary organisation, so we're a network across the UK. We have got volunteers kind of every corner of England. We've got volunteers in Scotland, we've got some volunteers in Wales. It's actually not Northern Ireland, so not quite true to say the whole of the UK. But we are a relatively small organisation. We've got about 180 active volunteers at the moment, but our coverage is wide. So we're spread quite widely across the UK to meet the needs of our service users. Adriana, would you mind just going on to the next slide? Thank you. So we are a trauma-informed organisation, and we offer accessible relationship-based support to those who are 6 months pregnant to 6 weeks postpartum. So doula support is non-medical pregnancy and birth support for women and birthing people, and we're there to support our clients in terms of sort of physical, emotional support, some practical support around the birth of their baby, and when their baby's very young, and then also we can kind of signpost on to other organisations. So crucially, we're non-medical, but we are there as a companion and somebody to kind of walk with people on this part of their pregnancy and parenthood journey. We work in very small teams, so we like to have a team of doulas who are supporting each client if possible, and our volunteers go on call to attend service users' births, as well as offering them pregnancy, birth preparation and postpartum support. Within our organisation, we have several in-house departments. So we have an infant feeding support department, we have a language support, and we also have various therapies represented. So we've got birth trauma therapists, we've got a psychotherapist who supports both our doulas and our clients if needed. We've got EMDR therapies, a whole range of things represented in that department. And as well as this, we've got a team of consultants, specialist people who work in local communities and offer surrounding support to our doulas working on the ground. So in our consultants department, we've got an infant feeding specialist, we've got a consultant obstetrician who supports our doulas when they need her support. We've got somebody who's a mental health specialist. We've got a social work consultant, and just recently we've got somebody offering developmental baby massage support to our service users through them working with Doulas Without Borders. So that's a little bit about what we look like as an organisation, and who we support. So we support women and people who are in financial hardship. We define that as without the ability to sustain a roof over their head, to pay their bills and to buy food. So really nothing for any kind of extras, any kind of anything additional to their very basic needs. In addition to this, the people we support are survivors and victims of domestic and or sexual violence, those with asylum seeking or refugee status. They may be survivors and victims of trafficking and modern day slavery. They may be experiencing homelessness, They may have experienced or being expecting to experience baby loss, or they may be aged under 20 and unsupported. So we have a very wide remit. We welcome referrals for people from all sorts of walks of life, facing all sorts of different challenges, and often facing multiple challenges at once from that list. So that's a little bit about who we support. Adriana, would you mind going forward? And yeah, as I've already said, I think we offer our services from 6 months of pregnancy up until 6 weeks postpartum. So that's a fairly kind of standard arc of support from a doula, but we end it perhaps a little earlier than you may end at your support if you are practicing privately as a doula, and that's just to allow us to kind of focus on being able to support as many people as possible, and also but also at the same time being there in that really critical 6 weeks following the birth of a new baby. So our reach, this is some data from our last year. So we supported clients in 21 counties across the country, and that was 81 clients that we supported in the last year. And I think that was something like about 90 doulas that we had in total supporting them. And we were able to support 81 out of 120 referrals, which we received last year. Now, we're not always able to meet the demand based on the fact that we're a voluntary organisation, and as I've already said, quite small and very grassroots, but we try and support as many clients as we can. Thanks, Adriana. What makes us different then? So there are lots of local grassroots doula organisations across the country. There are groups which specialise in supporting just one specific community, maybe even just from one hospital trust. And what makes us different to that is that we have this very wide remit, as I said, in terms of who can be supported by us, but also we have it's very broad because we can support anywhere in the country where we've got a volunteer. Also, our in-house departments, which I've mentioned, our infant feeding, our therapies department, and our language department, they all mean that we can offer a sort of 360 wraparound support from one hub. So it means that if a client has got needs around language translation and also needs help with dealing with past trauma, perhaps around birth, or preparing for upcoming birth, we can offer both of those things from one place without needing to have multiple teams involved, and I think that makes it really, really valuable for people, for service users who often overfaced with many different professionals in their care, and it can be quite overwhelming. So I think that it's really valuable for us to have multiple aspects in our one offering. It also means because of the way we work, it also means we can help when a family or a client is suddenly dispersed across the UK, so perhaps by the Home Office, sent to maybe another hotel or a different accommodation. And because we're UK wide, we can have that seamless sort of passover of support. So we may have one doula team in Hertfordshire who've been supporting a client, and then when they get moved to, say, Norfolk, then we might have doulas there as well who can kind of feed back to one another, who can support each other in then supporting the client without that kind of break in their support. So we find that that's really useful. So Katie asked us to kind of consider challenges that we've faced as an organisation and in supporting our service users, and I think those have been many. In the 6 years that we've been in existence since 2019, there have been so many small sort of challenges when you're building from the ground upwards, and we're constantly looking for solutions to them. One of the things that we have come up against is ensuring that our potential service users understand what our service offers. So even within our society and our culture here in the UK, understanding of the role of a doula is not consistent and not necessarily widespread. So when you throw in kind of people coming from other countries and with different cultures and different expectations, trying to kind of communicate the role of a doula, what doulas can offer, what they can't, the kind of support they can give, can be it can be challenging, but it's really vital. On occasion, we find ourselves referred to, because I think when a referrer is supporting a client and they feel that they are so desperately in need of additional support, it may be that they get referred to us, although actually perhaps the support which they need isn't within our remit. So quite often clients come to us and actually the root of their biggest challenge at that time may be finding housing or sort of sorting out other kind of structural issues in their lives. And so it can be challenging if we're referred to when perhaps we're not really the solution that client needs. And additionally, I think it's very challenging for a referrer. So many of our referrers are midwives, social workers, health visitors. We also have referrals from people in the community. So it may be people in religious groups or childcare, kind of like a baby group perhaps. So it can be really challenging for the person making a referral to us to fully explain what Doulas Without Borders can offer to that client in the limited time that they have, because we understand that maternity professionals are so overstretched with the amount of things they need to get through in a very short amount of time. So yeah, no, it can be challenging that that our service users don't necessarily understand what it is that we're offering them when they get referred to us. So the solutions that we've found to these issues are, well, firstly, we try to gain as much information as we can from a referrer when we accept a referral, but that often includes a back and forth conversation. So we have a referrals team at Doulas Without Borders who are responsible for that kind of relationship between the referrer and the organisation, and trying to get as much information as they can to support the doulas when they then go into supporting the client. It's also, we've learned, really important to kind of both try to fully inform a service user about what we can offer, and also to manage their expectations around the areas that we can and can't support them in. And we have recently spent a lot of time developing leaflets, which we're going to be sending to all of our volunteers. So when somebody signs up to volunteer with us, they'll be given a kind of information pack that they can use to distribute both in their community for potential referrers, but also they can give to clients when they start working with them. So they've got some, hopefully, simple to understand, informative information with signposts on to further kind of information about the role of a doula. And we're also working on having infographics on our website in a range of different languages. So with the option for referrers to share language specific information about our services with their service users at the time of referral. I think alongside the kind of day-to-day challenges, such as the one I've just shared, we've faced kind of more a structural challenge, I suppose, in relation to ensuring that truly informed decision making is possible for our service users when we're supporting them if they don't have English as a first language. So this is something that's arising daily across the country, and we really witness it a lot of the time. Our volunteers see this firsthand. So we found that translation services are not always available to birthing people at key decision-making times, especially during labour and immediately postpartum. So the sheer kind of overwhelm of that moment, of that time when somebody is in labour and they are in a country where they don't share a language with most of the people offering them care, can make this very challenging. So we've found that quite often the translation service available in that moment to our clients, maybe via a telephone, but it needs to be a hospital phone, which might be not in the birthing room. So we hear instances of service users, women who are in advanced labour, having to leave the labour room to walk down a corridor and speak on a phone at a desk in reception, for example. And this obviously, considering the sort of biomechanics of birth, is really far from ideal and can be really difficult and quite traumatic for that mother. And then when they are actually speaking to someone on the telephone, it may be that the translator who's available is a man, for example, which for a lot of women from many cultures would not be comfortable for them at that time. And additionally, it's not likely that the person on the other end of the phone has got the subject-specific understanding of birth, the language around birth, the understanding of the interventions that may be being offered. And it's just a fact of the way that translation services work is that it's not always possible for them to have that kind of that subject-specific language around what's happening for that woman right now. And therefore it means that, you know, these women are lacking the opportunity to give really fully informed consent and to participate in the decisions made about their birth and their birthing journey at that time. And I think it's a real an issue that we see. So we've looked at that, and the solution which we came up with is a Doulas Without Borders project called Mother Tongue. So Mother Tongue is a funded interpreted doula training for ex-service users and other bilingual women with asylum seeking or refugee status. So what it does is it offers either ex-service users or other women who are bilingual and who have the asylum seeking or refugee background. And it offers funded online doula training to these women and aims to give the graduates the tools to offer culturally aware, linguistically aligned, nurturing and advocacy for the women that they support. So it both populates our organisation with doula translators who can offer linguistic support and also culturally aligned, gender appropriate, trained language support. And it offers them, the graduates, the opportunity to become doulas and have new employment opportunities, or the opportunities to support other women and other people in their communities who also are facing similar challenges. And it's been a real success actually for us, because some Mother Tongue graduates are now employed by the NHS to support women in specific hospitals. So we had some interpreters working with doulas through Doulas Without Borders at Kingston Hospital. And Kingston Hospital saw the way it was working, and they said, we would like to actually have a relationship with these women, the interpreting doulas. And so they are actually now employed by Kingston Hospital. We've got a Romanian speaker, an Albanian speaker, and a Brazilian Portuguese speaker. And they actually can speak directly to the birthing person via their mobile phone, so they don't need to leave the hospital room. They can be contacted directly. They've got the language, they've got the understanding of the context of that the woman is in at this moment. So they're able to give them really culturally aware, but also an understanding ear and an understanding opportunity to be able to talk them through the choices that they're facing at that moment, and support them in making informed choices about their care pathways. So yeah, Mother Tongue is a fantastic project which we've seen really succeed, and it's become really central to how Doulas Without Borders hopes to kind of evolve, because it's proven to be a success for us, really. So I'm going to stop talking there, but I'll leave these with you. This is the link for making a referral to Doulas Without Borders. If you know anybody who would benefit from our support, or if you want to share this with colleagues, then please do. You can find our referrals page on our website. There's a Mother Tongue website also, and these are going to be sent out by Katie later on in a follow-up email as well. And I've also popped my email address in there, so if anyone's got any more questions about Doulas Without Borders or wants to get involved in any way, they can please do contact us. Thank you.
Thank you so much. That was absolutely brilliant. Great to hear. Thank you for sharing with us. Yeah, as Charlotte's just said on the sidebar, does anyone have any questions? We've got a few minutes to open up for questions if anyone has any, if that's okay, Grace. Yeah, so either if you'd like to come off mute and ask your question directly or pop it in the sidebar and we can ask. Yeah. Um, but if not, no problem. Oh, great. So Paula, over to you.
Hi, Grace. Oh, Grace, that was amazing. I've never heard of your situation at all. And I have been a previous midwife, but now I work in neonates. I'm really interested that even though your doulas obviously might not support the communities that I meet, could you still be contacted postnatally, even if they've not seen you antenatally?
Yeah, thanks, Paula. Definitely, we postnatal support on its own can be definitely something we can offer. Obviously, it just depends on availability at that time and the number of doulas we've got in the area. But definitely, it's something that we do offer, and we're quite often contacted by, say, a family who've had a very early baby, or yeah, it's something that we can definitely offer. Thanks for that.
Great, thank you. And we've got a question here from Jamie. Grace, do you think that doulas should be better integrated into the NHS?
It's such an interesting question and such a live one, and one that's evolving all the time. I think that we would love to see a better understanding of the role of a doula across the NHS. So we would love to see like greater kind of awareness of the role of a doula, and then the ability for doulas and midwives to kind of work seamlessly alongside each other, because of course the doula in many ways is there to support what the midwives are doing, and we would love to see that. I think it can be problematic potentially. So I have heard of instances where the NHS supports the training of doulas to work in a particular hospital so that they can have that more kind of integrated role. But then I think it becomes potentially problematic when they are trained by the NHS and they are there then more on the midwives, or that they've got a kind of a hospital expectation upon them more, because if they're integrated, perhaps they're not so good at playing the role of kind of impartial advocate for the client, and I think that makes it kind of potentially a little bit more challenging.
That's really interesting. Thank you for sharing that. And not a question, but yeah, somebody was just saying, and we've had lots of hearts on it, but just such a fantastic approach to addressing the issues around trustworthy and accurate translation when it comes to anything medical. So yeah, lots of thumbs up for mother tongue, and that's great. Any other final questions? I think otherwise, if not, a really big thank you, Grace. That was so interesting to hear. Really appreciate you sharing. And now we're going to move on to our next set of speakers. So that's Peter and Madinah. They're both from Bliss. So Peter Bradley is the Director of Services at Bliss and brings a real wealth of experience from a range of different organisations such as VSO and Citizens Advice. So we'll be hearing more from him. And Madinah Thompson, she's the Senior Information and Content Officer at Bliss. So really responsible for the creation and management of parent-facing information that Bliss produced to support neonatal families. Again, also bringing a really rich array of experience in Black-led organisations with a focus on equity-driven, community-led projects. So really looking forward to hearing to you both. Over to you. Thank you very much.
Hi, everyone. I'm just going to share my screen. Hopefully we can kick off.
Lovely. Thank you.
Just trying to actually put it in present view. Okay, can everyone see?
Perfect.
Great. Okay, fantastic. So yes, thank you so much for introducing us, Katie. My name is Madinah Thompson, and as she said, I'm the Senior Information and Content Officer, and I'm joined by my colleague Pete, who is the Director of Services. We're going to talk to you about a project that we've been running, which looks at the psychological impact of a neonatal stay on parents and carers, and particularly how those experiences affect Black families. I'll start by talking about the background to the project, and then Pete will talk about how this led to a development of healthcare professional focused suite of learning materials. And we'll aim to kind of focus on how we overcame challenges throughout the project, and there'll be time for questions at the end. So I'll hand over to Pete.
Thanks, Madinah. So yeah, I'm just going to do a tiny bit about Bliss. I've noticed in the chat that lots of you are from neonatal units or ODNs or from a neonatal background. Some are not. Most of you, hopefully, from the neonatal space will have heard of us. But we're a charity for the national UK charity for babies born premature or sick. We do work, and our mission is there. We do work trying to support outcomes, trying to improve outcomes for babies who need neonatal care, trying to give them the best chance of survival and quality of life. We do this by working with everybody who is important to the care of premature and sick babies, and that's the theme that we'll talk about a little bit more in a minute. I've put the pillars of our strategy, our new strategy, new this year, as a picture there to try to which both explains the work that we do, which is to support the care of babies, which is our work mostly with healthcare professionals, to support the voice of babies, which is our work with policymakers mostly, and then to support the parents and carers of neonatal babies as well. Also to emphasise that word equity, which we use a lot, and we do so really deliberately, and that's because, as we will talk about in this presentation, tackling inequality in neonatal care is really at the heart of all of our work. The other thing that we're going to talk about quite a lot, and we'll keep coming back to, is the idea of what's called family integrated care. Again, those of you from a neonatal background will, I'm sure, know this very well. But FICare, family integrated care, is a philosophy of care which is all about partnership between healthcare professionals and parents and carers in the care of their babies. We focus on that because we think we have a lot to bring to that space, but also because we know that lots and lots of evidence shows that it results in better outcome. Really good partnership leads to better outcomes. Babies. Crucially for us, we see the potential for FICare to tackle inequalities. Some of that feels really obvious. Working in partnership means working with individual families in really individualized and personalized ways, which we know is an important aspect of work to tackle equity. And we think there's a huge amount of potential there to support partnerships, supports equity, supports babies' outcomes.
Great. So this is just a snapshot of some of the statistics that exist for ethnicity and the inequalities in neonatal care that exist at the moment in the UK. And as we can see, they're pretty stark, pretty dire. But there are still big gaps in the data and discrepancies in the way that it's recorded. But I think the most important thing to remember is that overlying these stats are real families and real babies who are affected, and the understanding that the experiences that families have of healthcare, perinatal care, and neonatal care that are affected by race and ethnicity are also the memories that these families take home with them. So we're going to talk about the project, and when we approach a project, we're committed to our project values, which are really to listen to lived experience and keep listening. Experiences change, and it's important that we keep up with those changes, but also to work in partnership with community groups, other charities, and we know that that's how we learn and how we reach more people, and building trust, which is really key. You cannot overstate the importance of trust in order to really hear the true experiences of families and to create spaces for them to be safe and vulnerable. the aim of this project, again, to investigate the psychological impact of a neonatal stay, that a neonatal stay can have on parents and carers, particularly Black families, in the knowledge that there are significantly poorer health outcomes for Black women in maternity and neonatal settings, as illustrated by the statistics, and also to produce new information for families spending time in the neonatal care, and encourage early engagement and support. You know, we're not just doing this work to admire the problem, we want to do something about it and offer information and support to neonatal families that will then go on to improve the outcome of the babies. But in order to do that, we really need to understand the problem from a lived experience perspective. So the first thing that we did with this project was a UK-wide survey of neonatal families. The headline from that survey is that 95.6% of the parents and carers that we surveyed agreed that their mental health was negatively affected by their neonatal stay. These, you know, it's not a surprising outcome. I think one of the challenges that we had, though, was the diversity of the respondents that we surveyed. So 92% of the survey were white, and only 7% of them were fathers or non-birthing parents. So, you know, we're not getting a completely true representative understanding of what's going on. And also the fact that it was quite a limited sample size. So it's very kind of like a basic level understanding. And we also understand that qualitatively, what does it mean in terms of a lived experience? Like, what does this actually mean on the ground for families and for babies? So we went on to do a listening event, which was run by a partner with us for Black families in a rural setting. We wanted to hear from Black neonatal families about their actual experiences, and we couldn't do this on our own, which was obvious from the demographic breakdown of our survey respondents. So partnership was really key. So we partnered with Ian Morrison, who's a trusted facilitator in the area that we were doing the listening event. And we used a listening event model here to kind of build trust. And the first part of a listening event, you don't record anything, you don't have any audio or video recording, you don't take notes, you simply listen to what families have to say and what they want to share. And the second part of the session, you can record and take notes, but this comes after kind of the trust has been built and when families feel more comfortable. So this was a way to kind of allow families to have a safe space to talk about their experiences, and for them to kind of trust that we weren't there just to be exploitative or extractive of their experiences. I'm going to talk about the 7 key findings that we had from the listening event. It's really important to remember that most of these families had quite long neonatal stays, and that these are the strongest memories that they took home with them. So the first was the reality of their experience as Black parents wasn't fully recognised or understood. It's really important to remember that mental health doesn't present and look the same for everyone. Black people often feel the need to appear strong because it's not safe for them to be vulnerable in certain spaces. So we know that they already know about the statistics about maternal deaths and neonatal admissions. They know about the outcomes for Black families being poorer. So they're already arriving with that fear and that acknowledgement that it's not necessarily a safe place for them. And that's the background to them arriving on the unit. The next thing that we found was a real sense of profound isolation. You know, lots of these families were, at the time that they were admitted, the only Black family on the unit. And there was a real absence of peer support. You know, we had reports of them saying that, you know, no other family spoke to them or even would make eye contact with them, which is obviously really horrible and really compounded their feelings of isolation. The next was a reluctance to appear uninformed, which kind of prevented them from engaging with unit staff in certain ways. So an example of that is one father said that the information and support that he was being offered was completely different to the information and support that a white father with a baby in the next cot was being offered, as in it was lacking and limited in what he was being offered. We had examples of babies being taken away for tests with no explanation to the mother or father, and the fact that their fear of appearing uninformed was actually stronger than their ability to advocate for their babies. So another key one, which was really universal and quite striking, was that there was a real fear of having their babies taken away from all the parents. And these parents came from different countries. Some are from the UK, some weren't, different ages, different languages, different everything really. But they all had this universal fear that if they showed any weakness or asked for help, they might be thought of as not being capable and have their babies taken away. And this again challenged their ability to advocate for their babies because they felt that they should just keep quiet and not draw any attention to themselves. The next was a real gratitude for their neonatal care. There was a huge acknowledgement of how lucky we are to have the NHS and how good the neonatal care for their baby was. But this also meant that there was no space for them to request support for themselves as parents and carers. And there was also a real fear of being labelled a nuisance if you asked too many questions or exposed any concerns with the service that would again go against their feelings of gratitude. There was a real acknowledgement that what happened before they arrived in the neonatal unit was really key to their experience on the neonatal unit. The fact that many of them have experienced racism or microaggressions throughout their maternity care and, experienced cultural incompetencies meant that they arrived on the neonatal unit already having experienced things that really impacted how they could move through that space, and that there was a real failure to acknowledge the backstory and how much that had an impact on their experiences. Almost unilaterally, there was families really wanted more psychological services while they were on the neonatal unit, and they also really wanted unit staff to check on them more. So after the listening event, which I've just presented the key findings from, we also, as our kind of universal offering, conducted a full review, a PIF accredited review of the information for parents and carers and healthcare professionals about neonatal parents' mental health. So as part of this, we ran small focus groups with diverse range of families for accuracy. This is a different group of families to the listening event, to make sure that lived experience was at the heart of the new content. And these families also helped to review the written content that went out onto our website. So that was information for all neonatal families, web pages, specific information just for Black families about their specific experience, and a page specifically for healthcare professionals about supporting Black families. We also had a podcast, which was one of the outcomes of the listening event. We had two parents who met at the listening event and really wanted to continue their conversation about their experiences and to continue the work they were doing with us and highlight how their experience was impacted by ethnicity. And so they came together with us, and we did a podcast, which was called In Conversation With, which I'm going to show you a short clip from if I can play it. Let's see. Thank you. That was just a combined few sections from the podcast, which was a 45-minute session, and we also created a shortened version for healthcare professionals, which is shorter, also available on YouTube and on Spotify. And I think it's just really important to hear these parents speak for themselves, and I think can't applaud them any more for their honesty and the bravery that they had in coming forward and talking about their experiences so truthfully and in such a raw way. I think I'm handing over to Pete now.
Thank you. So I'm going to talk mostly about where we wanted to go with that project next, which I'll do in a second. But to say, I guess as Madinah has presented it, you can see the sort of journey that we went on with the work. We knew sort of strategically that we knew the importance of the mental health and well-being in the neonatal space. That's very well established. We wanted to produce some information that we know is a real need for parents and carers at that time on their neonatal unit, that really looked at that subject, that helped people to understand what was happening and to find ways of finding support. Because of our strategy to tackle inequality, we knew that we had some experience of wanting some real focus, some real depth on experiences of people who may face inequalities, and we know that ethnicity is a key factor in inequalities in neonatal care. So and as we got into the subject, what we found, Madinah is sort of underselling the work, I think, quite a lot. The listening event in particular really helped us to understand, we think, experiences in a way that we hadn't really fully heard before at Bliss, or not to quite the extent or to quite the level of depth anyway. So we worked really hard at that point to try to make that, to do justice to what we heard and what we felt we learned, and to try to make something that was really specific to that experience of Black families in this case, right in the heart of that information. So that's what we've ended up with there, is information for all parents and carers of whatever background, that looks at and helps them to deal with and find support for their mental health and well-being on the unit, with a real focus on Black experiences in particular. And that was, so there's a whole journey that got us to that point. We didn't want to stop there though. So as Madinah said, we didn't want to sort of admire the problem, and we use that phrase quite a lot, admire the problem, and not do something about it from a parent's perspective, and that's what we tried to do. But we felt like we had something else with the work that we had done, and we know that there are challenges to the challenges of inequalities around ethnicity are systematic, right? They affect, as we said at the start, we try to work with everybody who's important in the care of neonatal babies, and we know that parents are a key part of that. So are healthcare professionals, so are other audiences too. So we thought we should do more with that work than stop there. And so we tried to turn that into something that was deliberately focused on their healthcare professional audience. So we immediately, that's the next phase of the project really, which is where we're going to talk about. We wanted to take that learning that we got in order to influence practice, and spoke about care right at the beginning, to improve family integrated care, to improve partnerships with between parents and healthcare professionals. And we wanted to try to, and another challenge that we faced, or what we wanted to try to do, was try to get to the idea that the inequalities that we see here are both systematic, but they are also interpersonal. They're both about practice on the ground in neonatal units around partnership, but also about how systems work, about leadership, about management, about culture, as well as being about practice. So learning again from Madinah's approach with the information project, we knew that a big part of this would be to work in partnership. So we wanted to work with healthcare professionals who could help give authenticity and give important theoretical basis to the work, and researchers as well. But we also wanted to work with parents themselves and with community groups who had a real understanding of, in this case, Black families' experiences. And what we've tried to do is create a range of resources for healthcare professionals. They're about to be launched in the next week or so, so you're getting a bit of a sneak preview here. And what that work has resulted in is a whole series of things. We've an edit of the podcast, which Madinah explained. We've got some further parent stories that we've recorded and made into little videos. We've got 3 videos from a neonatal psychologist, and I'm going to talk about that in a second, talking about compassionate care and psychological safety on neonatal units, with an emphasis on minoritized experiences. We have 2 videos, short videos from an organisation called Black Mothers Matter, who are brilliant, and I'll show some of that in a second as well. And then we have another video coming from their health researcher at the Health Policy Partnership, which is all about that subject that Madinah started with, I think, which is about trust and why that matters. Well, I'm trying to press the cursor myself, but Madinah, you'll have to do it. So I'm not going to talk about all of those. I'm going to just focus on a couple of them. So the first is a set of 3 videos that very grateful to Davey Evans, who's a neonatal psychologist, and his company, their relational practice. He's put this together with us together. The first one focuses on the psychological impact of a neonatal stay. That's what's happening there and how practice and culture on the unit can respond to that. Talks about how the impact can be compounded by experiences of marginalisation. So it talks about this, quite a lot of themes that we explored in that video, and then talks about, again, what to do about it. So thinking about the culture of a unit to help support parents better. And there's a little quote from one of those there. You can, and you'll be able to see that info soon. The Black Mothers Matter videos, 2 videos, they focus on 3 aspects of what is presented as cultural safety, which is a development of a phrase that you sometimes hear, cultural competency. They talk about the difference between those things, and then they focus on 3 areas of cultural safety, which is the difference between intent and impact, the effect of the nature of power dynamics in relationships on neonatal units, and this lovely phrase that they use, which I think is great, explores a lot, which is about the idea of being curious but not overcompensating in your relationships with parents and families whose background is you do not share, you do know so much about. I'm going to show a little bit of one of those videos, if you don't mind pressing play there. Thank you. So I should have said yes. The sound is quite quiet there. That's a sort of finalised edit that we're finalising now. That was Sonna on the left and Caprice on the right there from Black Mothers Matter. And what they're talking about there is one of the second of the videos actually, which really focuses on what you can do, and what they're giving there is an example of what they call internal and external scripts, which are sort of designed to help practitioners think through conversations and relationships, and then what to do in those relationships. So a really practical sort of focus on action. Sorry, Madinah, do you want to flip to the next one? And then the other of the videos that I wanted to just highlight a little bit is the one from a researcher called Lucy Morgan, who works with the Health Policy Partnership. She's just finalising this one, which is about work that she has done completely separately to Bliss, actually, on it's called 1 Million Conversations. It's about trust in healthcare systems and how trust is crucial to tackling inequalities generally. It's really good work, we think, and we saw that presentation and thought that has a lot to add to this space around family integrated care and around the psychological impact of a neonatal stay. So this is there's a short video on that theme as well. The idea that building trust leads to trusting relationships, leads to better partnership, leads to better care, and trying to think about that in the context of minoritized experiences and neonatal care. That's another one.
Thanks, Pete. So I think in kind of a bit of a summary, the project kind of led to these outcomes for families. So as we've mentioned, new content, universal content for all neonatal families, about understanding how your mental health can be affected by a neonatal stay and what you can do and how you can be supported by information and actual support. New content for Black families specifically, tailored information about those experiences and how that can be affected by your race. And then the In Conversations with podcast. And we also created a mental health card, which is free for anyone, healthcare professionals or parents, to order from the Bliss shop. Then the resources for healthcare professionals, which Pete talked about. So this new content, this series of training videos created by a variety of experts. We also have the shorter edit of the podcast, which is specifically for healthcare professionals, a page on supporting Black families, and a poster to display on neonatal units. The real summary to this is that from this work and the work that we've done before this, we'll really continue to listen to the experiences of all families, but particularly to focus in on families who are affected by health inequalities. And that listening to that does continue to shape our work. You know, we want all of our support and